Good morning, everybody, and welcome to this morning's session of the Psychological Professions Week. My name is Sharon Prince. I'm a consultant clinical and forensic psychologist, Deputy Director of Psychological Professions in Leeds, and also the Chair of the North East and Yorkshire PPN. I'm very excited about this morning, which is focusing on making all health and care psychological, one of the commitments of the PPN. Next slide, please. In terms of housekeeping, for those of you who may or may not be familiar, we have Slido. So please post your questions in the window on the right-hand side. We'll be having a Q&A session after each presentation. So think about what you might want to ask presenters and we'll try and collate them together towards the end. If you experience any technical issues, please contact the webcasting at firstsightmedia.co.uk. Please note these sessions are being recorded, so if you don't want your name to appear, please post anonymously in Slido. There'll be more information at the end of the session about evaluation and how to get an attendance certificate, so please sit back and we hope you enjoy the session. We're just going to play a short video which illustrates the commitment of today's session. Thank you.
We know. You've seen many a vision come and go. We're trying to do something different here. In 2020, we went on a journey to co-create a more impactful and unified future for the 12 psychological professions so that we can deliver the best possible care and support for everyone in our communities. We had over 1,800 people coming together to share over 12,000 ideas, comments and votes about our vision for the future of the psychological professions and the commitments we must all make to achieve our visionary goals. A vision for the psychological professions. To transform lives and communities by extending and embedding psychological knowledge and practice across the whole of health and care. Here are just some of the commitments. Make all health and care psychological by enabling all health and care services to deliver psychologically informed care. By expanding access to the range of evidence-based psychological therapies and interventions to those who can benefit. Now, we want to make this vision real. We want to bring it down from these visionary planets to our blue and green planet Earth and connect it with everyday life. We are calling this process the Intergalactic Bridge. Over the next few months, join us in creating the Intergalactic Bridge. Tell us what's been working for you and your ideas on how to make this real. We'd love to hear from you.
Hello, I'm delighted to be here today. Thank you very much for inviting us. So I'm here to talk about bringing psychological leadership and formulation to interdisciplinary team working with complex patients in general practice. So today I've got a team of people with me. So I'm Dr. Suzanne Hayward-Everett. I'm a consultant clinical psychologist and clinical lead of the primary care wellbeing service in Bradford and Airedale. And joined with my colleague, Dr. Sari Haranwell, who's principal clinical psychologist. She's also clinical lead of our chronic fatigue pathway and our long COVID pathway for staff. And also Dr. Rachel McHenry, who is a GP with a special interest in persistent physical symptoms. And we're delighted also to be joined by a person with lived experience, Jenny Birch, who's going to be talking today about her own lived experience of working with the primary care wellbeing service, as she has long-term conditions and significant persistent physical symptoms. Next slide, please. Over to Rachel.
So I'm going to tell you about the problems in general practice. And I think fundamentally, all of these things just don't allow staff to have any headspace to think outside the box. So we've got an ever-increasing demand, which is obviously affecting the whole of the NHS, but particularly in general practice. And that makes it really difficult to look after patients who are very complex. Care is very fragmented. You don't really have a hold of what's going on, and people are falling through the cracks that way. There's lots of bureaucracy, again, affecting everywhere in the NHS, lots of top-down initiatives that are not necessarily improving patient care, but taking up lots of time in general practice, because that's what our income is based on. There's lots of knowledge gaps as well, so this is very concerning. So I teach medical students, GP trainees. Often this isn't part of the curriculum. There's a new exam that's been issued by the General Medical Council for medical students. So every medical student in the country has got to take this medical licensing authority exam. And looking at those questions, there's nothing on chronic pain, chronic fatigue, complexity, and the problem is if somebody is examined in it, then they don't take it very seriously, and then this has a knock-on effect then throughout people's career. We notice because of the way medicine is structured, with very sort of super specialists looking at their own little bit of the body, there isn't any kind of joined up way of looking at the whole person. So that's a problem. And then because there isn't that knowledge background for medical professionals, patients often get mixed messages about their symptoms and what's actually going on for them. And everything's very medicalised when it shouldn't be. There's obviously increase in digitalisation, which is helping for patients access more easily, but I wonder whether that's affecting our care of patients, particularly patients with complexity, being writing emails to GPs or doing more on video and telephone. You feel that there is this lack of being able to borrow our brains and process things properly. So I think there isn't really an understanding of how digitalisation, affects the doctor-patient relationship, and potentially for complex patients, they need to see us face to face rather than in this way. There's obviously increase in litigation everywhere. People are worried about missing things. So often patients are exposed to unnecessary test investigations that perhaps if somebody had the time to ask the right questions, they wouldn't need. But everyone's worried about people taking things further if things are missed. There's obviously an exodus of staff, which is affecting a lot of areas in the NHS, but particularly in general practice. We've got a large cohort of people retiring early, and that is obviously a problem with not having many permanent staff. More people are going into locum work, which is what I've done personally as well, just to be able to manage workload better and not feel so pressurised, not feel so unsafe as it does at the moment for a lot of people. But the problem with that then is there's a lack of continuity when you're a locum. So there's that makes it more difficult then for complex patients who are often seeing different members of staff, and lots of people don't work full time as well. So patients don't have access to those same members of staff every day. And I think really key is having the right combination of staff to provide the care the patient needs. So general practice is still very medical heavy, so there's lots of GPs, nurses, and not enough of other sorts of staff in practice to really have a proper holistic way of looking after a patient. So I did an audit, it was about 10 years ago actually, but very similar findings probably now, where 5% of our patients were creating 25% of our workload. And when you went into patients' records in a bit more detail, majority were medically unexplained. They'd been on the medical merry-go-round of lots of different specialists not being able to find what was going on. Often the question, what's happened, rather than what's wrong, wasn't asked. There's often past history and present history of traumatic, stressful experiences. And my conclusion many years ago was for my colleagues to stop being so biomedical and needing better access to psychology. which is, it sounds like this is what this morning's all about. So that's fantastic. So I'll pass back over to Suzanne.
Thank you, Rachel. Next slide, please. So as a result of Rachel's fantastic audit, the commissioners across Bradford and Airedale set up the Primary Care Wellbeing Service with 3 aims. Initially, it was set up as a cost savings initiative, and we had to demonstrate that we made savings. We also had to demonstrate we were improving quality of life for patients. And our remit was around complex patients with long-term conditions, and then it was medically unexplained symptoms, and wanting a more holistic approach, so a biopsychosocial approach. So that started the Primary Care Wellbeing Service around 2016. We started off with temporary funding. We were able to demonstrate significant savings, improved quality of life, but also what we significantly saw is that patients were having much more of a wraparound care. So rather than having to see multiple consultants, multiple care plans, we're able to bring all of that work into one care plan with overlaid by a psychological formulation. Next slide, please. So the Primary Care Wellbeing Service is developed, and you saw on the previous slide, we've won lots of national awards, but we primarily are clinical psychology led. We do have counsellors on our service as well, assistant psychologists. We have a manager. We have physiotherapy, occupational therapy, a specialist dietitian, a personal support navigator who has a role of supporting people around benefits and housing. We have high levels of deprivation across our patch, so it's really important. We support people with those primary needs as well. And we have admin support as well. We're fortunate now to welcome Rachel on our team more recently, so we also now have a GP. Next slide, please. And as I mentioned, we were asked to demonstrate the changes that we made to patient lives, and we were being externally evaluated a number of times, and we were able to demonstrate significant changes in people's lives. We saw a decrease in activity of non-elective admissions and elective admissions, as well as A&E attendances. So again, these people have complex physical and mental health, so sometimes there were a lot of unmet needs around neurodevelopmental challenges, undiagnosed autism, a number of other trauma-informed learning disability formulations that we supported GPs with. We saw a significant reduction in GP appointments following referral to our team. And on average, there was a decrease of 577 per patient, and this evaluation was over 6 months, just of a small cohort of patients, about 60 patients that were followed up. But following referral, there was a total decrease in secondary care costs of over 37,000. And I guess we found within the first 6 months that we'd actually sort of paid for our team in terms of the savings. Some of the savings we weren't able to measure. So, for example, when we worked with the GP, so we meet with GPs regularly, and we're able to sometimes prevent unnecessary surgery, as well as some sort of reversal of long-term dependence on aids, etc. And those costs we couldn't include in this. So these are basically costs looking at previous history of usage of care. So they're focusing on the total change in cost of long-term conditions. The results show a high decrease in total in secondary care for each patient, over 20,000. Next slide, please. So what we recognise is this paradigm shift, and Rachel's highlighted the challenges within general practice. And we felt very welcomed in general practice to support GPs with these patients that they were seeing on a regular basis, but actually feeling that they were witnessing these patients decrease in their physical and their mental health, and yet not feeling able to fully provide a holistic model with these patients, and which is what they needed. So we've been able to demonstrate this, and there's a few publications here from King's Fund where we've been cited, as well as the Centre for Mental Health. And more recently, we were lucky to be awarded a BPS grant and work closely with the NHS Confederation and Centre for Mental Health around how we can support better primary care. And we have just written a consultation document for commissioners around commissioning psychological leadership within primary care and the benefits of that. So I'm going to talk a little bit more about that later on in the presentation. And I'm now just going to hand over to Sari for the next slide. Thank you.
Thank you, Suzanne. Next slide, please. So I'm just going to talk a little bit about our pathway. So as Suzanne explained earlier, we were commissioned originally to work with GP practices to on these aims of improving care whilst reducing cost. And moving forward, we weren't really sustainable as a service to only serve a few numbers of GP practices. So we have now expanded and serving all of Bradford, Craven and Airedale area. So the pathways that we have developed as a result of that is a persistent physical symptoms intensive therapy pathway, a persistent physical symptoms standard pathway, a chronic fatigue syndrome ME pathway. I don't know why that's in green, but never mind. And a COVID-19 rehab pathway for staff. So the intensive therapy pathway might be for people who have really significant physical and mental health problems. They might be immobile, they might be bedbound, they might require several home visits in a week. They likely require significant liaison with outside agencies and often have multiple consultants involved in their care. They may be a bit less psychologically flexible and may have more physical input in terms of OT and physiotherapy. Some people might be discharged at the end of that pathway, or they might move on to the standard pathway. The standard pathway is for people who might be a little bit higher function in the community in terms of the physical. They still have multiple physical and mental health difficulties, but they might be more able to participate in daily activities. And they tend to start with a group pathway with some individual input as needed. On the chronic fatigue syndrome ME pathway, the standard pathway there is to attend an 8-week lifestyle management course. If people are not ready to attend that, they will have some input to help them become ready for the course pathway. And there's various additional courses on the pathway, such as a compassion-focused 6-week course, a 3-week breathing course, and a 5-week back to baseline course, which is facilitated by physio and OT. And more lately, we've developed the COVID-19 rehab pathway for staff, and we're publishing on part of this pathway December, January, I'm hoping, on the evaluation of our 7-week virtual recovering from COVID course, which is the key part of this pathway. But it's really, again, a wraparound MDT with the same courses as on the CFS pathway. So really what we are doing that's perhaps different is that whole wraparound care, working with the patient where they're at, whether it's home-based, virtually, or inviting into clinic. And obviously because of the pandemic, we've been forced to move much more into the virtual work. And we really work with the system. So if there are multiple teams or consultants involved, we often call for a professionals meeting to have a shared understanding with the service user in terms of their formulation, and helping the healthcare professionals as well to understand persistent physical symptoms are better to increase that sort of understanding and empathy. And really importantly, in terms of thinking about Maslow's hierarchy of needs, if people have significant issues around being safe in their own home, or having access to food or a roof over the head, then that really needs to be addressed first in order to be able to move on to other forms of rehabilitation. Next slide, please. So this slide is really about this is how it can feel like for patients in the NHS. So being seen by lots of different consultants, different doctors, and not having that shared understanding. So each doctor just looking at one isolated part and maybe not connecting it also feels very fragmented for the patient, and doctors might also be struggling with understanding what's going on, as some of these investigations might come back repeatedly with nothing found, even though the symptoms are severely impacting on the quality of life for the patient. Next slide, please. So what do we do that's different? We really ask questions around the person's history, trying to link the symptoms up. So when is your breathing worse? When is your pain worse? When did it start? So when did the asthma start? When were you diagnosed with diabetes or with CFS? And really track that to help people really integrate that kind of understanding of there isn't really a separation between the brain and the body. Everything works together, and we have, you know, a fantastic kind of control center up in the brain, but it's also kind of bidirectional feedback loop. So the gut feeds into the brain feeds down, affects digestion, our heart rate, our breathing, and so on. And if we're not breathing well, that's going to really significantly impact on our quality of life and cause all sorts of interesting symptoms. So really thinking about how all behaviours and symptoms link up, and tracking the history of it. And really wanting to support people and taking their symptoms really seriously. We really try to demedicalize and reframe. So even though we're kind of saying, yeah, there's something going on here, but maybe there is a different way other than medical investigations. So really, if, for example, we have some people that might be have a very sensitive system, and they might their body might look like it's overreacting to a paper cut by swelling out the whole hand, and we'll say things like, that looks perfect, your body's doing exactly what it should be to protect your hand, but let's look at how maybe we can decrease the sensitivity of that immune system. And we really look at evidence and guidance kind of beyond the NICE guidelines, as well as consultant and NICE guidelines. What we know is a lot of the NICE guidance is very outdated, and it only considers, doesn't consider the broader context. It only considers evidence for a very narrow part. So we're really looking at influence, culture change, and feed into all of the systems in the NHS, but also outside of the NHS, so linking in with voluntary sectors and so on. Next slide, please, and I'm going to hand over back to Rachel.
Thanks, Sari. So yeah, why this works from a GP perspective. So I've worked with a team in general practice, and obviously lucky enough to work with a team now a couple of days a week. And I think with this team, it's about having time and the skill set to sort patients out properly, and that sort of addresses some of the previous things that I mentioned, the problems that we're facing with lack of continuity, problems with litigation. If you've got time to look at a patient's records properly, and you've got easy access to psychology, physio, OT, care navigating, dietitians, if you've got really easy access to that, and you can, we meet on a daily basis and are able to feed back to each other and get those skills, and get the patients being properly sorted out. So that's a really big thing in this team. Being able to oversee the patient's care, protect them from further unnecessary investigations and procedures. So because there's lack of continuity in general practice, having this team just being able to kind of have a hold of what's going on, and as Sari mentioned about being able to involve other health professionals. So we've got a meeting coming up soon where we've got community matrons, district nurses, consultants in the hospital coming to talk about this particular patient in order to kind of unpick what's happened, and also to stop the mixed messages from happening, so the patients we're all singing from the same hymn sheet, the patient's getting the same message from everybody, which is really important. As Suzanne said, we reduce frequent attendance. Patients have a so much more positive and appropriate experience of medical care as well with this team. And I often hear patients saying that they just feel believed and understood for the first time. They've been properly listened to. And one of the lovely things is when they say, "You've given me hope for the first time. I was told I had to live with this and just put up with these symptoms, and actually you've given me the hope that I can live a different life without some of these." So that's a really, really great gift to give somebody. As part of the team, so I was teaching GP trainees last week about chronic pain. I teach medical students, so we were involved in training to try and spread this message out and have health professionals having better way to explain symptoms to patients. So as well as doing that training, also, from that meeting I spoke about, being able to talk to specialists about the patients they're involved with, and giving them a different way of looking at their patients as well, is hopefully again disseminating this message across, so that there's an ongoing education that way. We're looking at doing further joint working and training and providing some consultation support tools and things like that. So we're very much part of not just keeping this within our team, but spreading the message out. And I know myself, when I was working with the team as a GP, it's very isolating in general practice, and it was fantastic working with this team. I felt so much more satisfied with my job, but there was, you could see the morale lifting in the team I was involved in. And when I moved practices, I moved to a different practice that didn't have this team, you could feel yourself dipping, and you could see that the struggles that my colleagues were experiencing. So, this sort of team, needs to be everywhere. And I think, if we're approaching things from a medical perspective, we're missing out, obviously, on the psychosocial factors that determine health. And it's so important to have a team that can deliver those ways of looking at things. And this is what this team does. So I'm going to pass on to Jenny now, I think, who's going to give us her experience of being with the team.
Are we there? I wouldn't be here without this service. I wish you could see a photograph of me when I was discharged from hospital last year, and the state of me. It's that holistic approach from my point of view that has been absolutely life transforming. you know, I'm still very fragile, but I know they've got my back. And the point is the connected thinking. It's joining the dots. It's the fact that my world-class psychotherapist, talks to my physio, and my physio will talk to my GP. And I cannot tell you just how much would be saved in the NHS if the dots were joined. I have made more progress in 15 months with primary care wellbeing than I have in 45 years of chronic health problems. And I think it's about, you know, just listening to the other contributors. It's about communication, having time to read the notes, having respect for the patient's own knowledge of their conditions, and supporting them with consistency. The effort it takes to join up the dots if you are on your own is so detrimental to your health. So I thought I'd just, you know, my referral to primary care wellbeing has really been the most important intervention in a lifetime of medical appointments. You get sick of seeing them on the calendar. And medical appointments, hospital stays, treatments for trauma, heavy medication, mental health interventions that last for, you know, you have 6 hours and that's it. That is not a way, as a grocer's granddaughter, that is not the way to run a business. And this organisation has become my rock and my anchor, and I'm recovering from a series of illnesses that are so relevant to what's being said. So in the last 10 years, I have suffered from severe osteoarthritis. So I've now had 5 hip replacements and 17 dislocations, which means I'm hospitalised every time it dislocates. I also have had depression and anxiety from being very young. And I have a history of both rape and severe domestic abuse from 2 separate offenders. I have a very poor relationship with food. So I'm either eating too much or I stop eating altogether. That's my history. In December 2019, I was hospitalised and I didn't come out until August 2020. And there were multiple health issues, so including COVID and malnutrition and skin infections. And I was even misdiagnosed with scabies, for goodness sake. It was that bombardment of different consultants and different doctors that made life so much more difficult and makes life so much more easy now. I think that you know, during last year, my leg dislocated, and again for the last time, and I was told I would never walk again. And in actual fact, primary care wellbeing have supported me with a different surgeon, and I can walk now. And I think that from a patient's point of view, you are just totally overwhelmed by how many letters come through the post, how many things you have to put on your calendar, and the fact that there is the liaison between these professionals, aside from the fact that they are so good at their job, is what is crucial. I mean, it's just common sense to talk to each other from my point of view, and it doesn't happen. And I also need to say really that it's not just the effect on me, it's the effect on my family, and particularly my elderly parents, who have struggled for years to try and get me and help me with my health. And their health has massively improved as a result of my rehabilitation. And so that saves the NHS so much money. And I wanted to just share with you some of the outcomes. I find myself beginning to do things that I never expected to do because of the connection between these professionals. So I'll give you some examples. Make new friends. Reconnect with old friends that I haven't spoken to in some cases for 30 years. I'm having lunch with a friend I haven't seen since sixth form tomorrow. Breathing, drawing and painting. I write every day. I can read again, and that's always a measure of how, in terms of my mental health, how well I am if I can read. Listen to music. People tell me I laugh more. I can stand up for myself in difficult social situations without either terror or aggression. I'm managing my pain better. I can sleep. I can cook and enjoy eating healthily and managing my weight. And I'm even putting my makeup on, for goodness sake. And I think, to my utter astonishment, having consigned myself after so much sexual abuse, even considering, going out and dating again and having a relationship, which I never thought would ever happen to me again. I can also now walk, and having told, I would never walk again, that is a miracle. And that is because I have developed the combination of a different state of mental health and physical support in terms of physio. This service, through its kindness and its professionalism and its respect for me as a patient, and that holistic approach, and most importantly for me, the communication between professionals. It's, as I say, it's done more for me in 15 months than years and years of interventions. And I just think we should consider how much money could be saved if this was a model for the future of the NHS, and that, how many more satisfactory and promising outcomes could be achieved by that. It's the economy and common sense of thought that makes this work. And as a sort of, I was a history teacher for 20 years, and arthritis meant that I had to give up teaching. I'm now looking at different opportunities to go back into work. I'm also, as a history teacher, very aware of, Bevan's vision for the NHS, and that it has so many excellent and amazing qualities compared to other countries, but there is a huge amount of waste. And when Bevan launched the NHS, it went into receivership within 48 hours. And I think there needs to be this joined up thinking, this basic, sensible, joined up thinking between professionals if it's going to work in the future. There's primary care well-being, and I need to say this publicly, is I absolutely ardently believe a model for change and a model for the future. It's changed my life. It's changed my family's life. And I would just like to say publicly that for me and my family and my friends, my loved ones, I am enormously indebted to this team and the way they work together. It has been transforming for me. Thank you.
Thank you, Jenny. So it's back to me. Thank you, Jenny. That's so inspirational, and just really, really moved by your story there. Thank you so much for sharing that today. And I'm sure that you've touched lots of people in relation to your experiences and how you've benefited from the service. And that's been lovely to hear some lovely examples there as well. And that comes with a lot of hard work as well. So, but it has been an absolute privilege to work with you. So thank you so much, Jenny, for being here today. We do have a brief video, but I'm not sure if we have time. So I'm just going to check with my colleagues if we've got time to just share the video.
No. We need to do one question now.
Okay, great. Okay, what we can do is maybe share the link to the video in the chat so that you can watch that at some other point. But that comes to the end of our presentation today, and I'm going to hand you back to Sharon.
Thank you. Hi, thanks, Suzanne. Thank you so much, Jenny. That was a fantastic testimony. Thank you for sharing your experience with us of the team in Bradford. Thank you for the other presenters. We have about a few minutes, so we've had loads of questions come up. So I'll try one, and I think there are two questions I'm not avoiding. There is a question about given the overall workforce challenge, could we be making greater use of health psychologists as well as clinical psychologists in primary care? And I'm not going to ask you to answer that one because I think this might link to our second presentation, and we'll take that question in its entirety at the end, if that's okay. Does that make sense? Okay, so what I will ask you...
The short answer is yes.
Yes, and I hope you might think a bit more about that in the second presentation, but yeah, absolutely. Just a question, because we are running over, but I just wanted to put that to you. It's come up a number of times. People are asking about trying to understand the link between this service and IAP services. And are you integrated into an IAP service? What's your relationship with IAP service and long-term conditions?
Can I take that?
Yeah.
Sure,
so the people that we see, I think they have significant comorbidity, but they also have quite significant mental health problems often as well. But they would not be accepted by IAPT. We don't have an IAPT long-term conditions pathway locally, but generally what we find is that what we understand from the patients we work with, and as Jenny's explained, we're not unidisciplinary, we're interdisciplinary. So the patient, we don't just work with one symptom or one problem. And our patients have potentially diabetes, heart failure, asthma, depression, anxiety, trauma. There's a sort of multitude of problems. So what we tend to find with IAPT is that it tends to be a one health professional, psychological practitioner working with an individual around a manualised approach. But because our patients have so much comorbidity, we have to do a lot of practice-based evidence. It's very much formulation driven. And we'll be working with people potentially, as you heard from Jenny, so often longer term as well.
Okay. Any other comments? That's really helpful. Makes sense. I think there was a concern that kind of separation would lead to perhaps silo working, but you're talking about your service being constructed in a very different way, organised in a very different way. I'm really sorry. There were a number of questions, but we have run over time. So if you stay with us, I know you will, maybe we can, if we have some more time at the end of the session, we can come back to you all. But can I say thank you so much. That was really inspiring and just a wonderful illustration of the impact of interdisciplinary working in action, really. So thank you. Okay, so if I can now welcome our second presentation, our second presenters, excuse me. Can I introduce Dr. Elizabeth Jenkinson, health psychologist working with working as the National Training Director for Health Psychology and Workforce Redesign, and also Lucy Rennick, who's Workforce Transformation Lead for Innovation and the Transformation Director at Health Education England. I'm really looking forward to this as well. Thank you.
Good morning, everybody. And gosh, how do you follow that wonderful presentation? It was fantastic, really inspirational. I'm Dr. Liz Jenkinson. I'm a health psychologist. I mostly work at the University of the West of England in Bristol, training health psychologists. But I'm also seconded to Health Education England. And I'm now the National Training Director for Health Psychology and Workforce Redesign. And we're going to talk a little bit about that today in our session called Applying Health Psychology to Make All Health and Care Psychological. I'm just going to hand over to Lucy Renwick, who's my partner in crime at Health Education England, to introduce herself.
Great, thanks Liz. Good morning everybody. As Liz said, I'm Lucy Renwick, Workforce Transformation Lead at Health Education England, and part of the programme that we're going to talk about today in terms of health psychology in workforce redesign is a piece of work that I'm leading internally at HE. So Liz will take you back through some of the kind of background information and some health psychology information, and we'll talk to you about the programme in a little bit more detail shortly. So back over to you, please, Liz.
Thank you, Lucy. I'm going to try and turn my slide over, but I don't think it's working. So next slide, please. Thank you very much. So just today, I'm speaking on behalf of a group of us. So Professor Angel Chater, Adrian Whittington, Professor Joe Hart, Professor Lucy Byrne-Davies, Lucy and I are all part of the Health Psychology for Workforce Redesign group that sits within Health Education England. And this is a very new grouping where we're hoping to include health psychology and embed it a little bit more within workforce redesign in the NHS. So I'm speaking on behalf of a wider group of us, and Angel will actually be joining us at the end as well for some questions. Next slide, please. So in summary, what we're going to cover in our short time together this morning is what health psychology is, as some people will know and some people in the audience I'm sure won't be sure, and what health psychologists do. So who we are, what we do, where we're based, and what sort of work we engage in. I'm going to introduce the pivotal role of health psychologists in making all health and care psychological, particularly in NHS work. I'm going to consider with Lucy the role of workforce redesign and define that term and think about how that can help in growing capability and capacity in the NHS. And we're going to outline an innovative training pathway that we're developing to support the development of health psychologists working within the NHS. And then hopefully we'll have enough time at the end for a question and answer session with myself, Lucy, and Professor Chater. Next slide, please. So what is health psychology? Well, this syncs really, really well to the previous presentation, where we were talking about a holistic view of seeing a patient's prevailing health issues and how we might be able to help. So health psychologists work in a biopsychosocial model, a holistic model, in a very similar to way to what was just being described. So that's brilliant for us. This links really, really well into what we were just beginning to talk about. So health psychology can be defined as the study of psychological processes in health, illness, and in healthcare. We tend to adopt a biopsychosocial approach. So as we've said, thinking about some of the biological, biomedical, maybe neuropsychological aspects of health conditions, and the psychological, so how people are thinking, feeling, and behaving around their health, but also the social, so people's life, people's culture, people's immediate environment, people's family, some of the issues that were discussed in the previous testimonial there, which was really fantastic from Jenny, hearing about all the many issues that might affect people's health. So we apply our understanding of the psychological processes underlying health and illness to a number of different areas as health psychologists. So one is the promotion and maintenance of health. So trying to support people to engage in healthy behaviours. Perhaps that's take their medication, perhaps that's exercise, perhaps a healthy diet, and working with people to make those choices and to help them engage in those behaviours. And then the analysis and improvement of the healthcare system and healthcare policy formation. So we might work on a policy level on thinking about how things work within the healthcare system and how they might be improved. We also look at health promotion in terms of the prevention of illness and disability, so working in public health settings. And we also want to help enhance outcomes for those who are living with illness or disability. So working perhaps clinically or therapeutically with clients who may be living with illness or disability, or working with organisations who help groups of patients as well. Next slide, please. So in summary, we're a psychological profession. So we're here to talk about psychological professions this week in their many different guises and what we can bring to helping folks, and particularly what we can bring to the National Health Service. So like many other flavours of psychology and training pathways, health psychologists promote excellence in psychological health and well-being. And if you want to know more about health psychology and how we fit with other psychological professions, there's lots of information on the Psychological Professions Network website that you will have accessed the live streams on today. Next slide, please. So in summary, health psychologists are Health and Care Professionals Council regulated. So they're health professionals who are regulated by a governing body in the same way that clinical psychologists would be, or podiatrists, or occupational therapists. And so we sit under that regulatory body as registered health professionals. We're educated to doctoral level, and we use our psychological science to promote health, as we've said, prevent illness and improve healthcare systems. And it's the improve healthcare systems bit that we're going to focus on a little bit more today in our discussions about our new project. So in terms of health psychologist competencies, the skills that we have, and those extra things that we might bring to the workplace, all health psychologists are trained in behaviour change, so helping support clients and patients to change their behaviour where they might be wanting to. So that might be around health behaviours such as eating, sleeping, exercise, for example, medication adherence, but it might also be behaviours in the workplace. So how do we become more effective in the behaviours that we engage in to help our patients, for example? We also are trained in psychological interventions. These may include models like motivational interviewing, cognitive behavioural therapy, mindfulness, for example, and we use those within the context of helping people with health conditions. We also are trained in teaching and training, so how to teach others to perhaps deliver this sort of work, how to teach about our subject, and also how to train people to be more psychologically informed in the work that they do. We also research, like all doctoral level psychologists, so we know how to gather together the evidence and be critical about it. And that was again mentioned in the previous talk, how important it is for us to stay on top of the literature and be working in sort of an evidence-based way. We also engage in consultancy, so we're trained to develop work for where we're perhaps working for others outside of our organisation, things like making contracts, negotiating, working perhaps privately as well. And we generally teach professional skills, which is true of all psychologists. We need to be really strong in terms of our understanding of ethical practice, safeguarding, confidentiality, good note keeping, and generally adhering to the British Psychological Society Code of Conduct, that we're developing our skills in a professional way. So we're credible and we're doing no harm in terms of our practice. So we're very, very well trained, as are all psychologists, in a lot of areas that might be really helpful within work within the NHS or in other settings. So on completion of training, folks become either a practitioner psychologist, a health psychologist, and a chartered psychologist. So we're regulated both by the Health and Care Professionals Council and the British Psychological Society. Next slide, please. So where do we work? Well, lots of places across a range of healthcare settings. So that might include primary, secondary or tertiary care, in statutory, third sector or private healthcare. And I run training courses at the University of the West of England, and we see lots of our graduates go on to work in a really wide range of settings, delivering this kind of work. Folks might also work in large-scale public health programmes, so designing, for example, messaging around vaccination, around other kind of preventative health behaviours, and with organisations to support individual or small groups of people with health conditions. Health psychologists, of course, also work in academia, as many psychologists do, teaching and researching their area of expertise. Now, we're quite a big group of professionals, but we're not anywhere near as big as some of the other psychology groups, and we'd like to address that, obviously. We think there are about 610 of us in the UK currently registered qualified health psychologists, and around a sixth are estimated to be employed directly in the NHS. And there's a link to that document there at the bottom of the slide if you want to read further on health careers in the NHS. Next slide, please. And if you're really interested to find out what people really do as a health psychologist in their day-to-day work, the British Psychological Society Division of Health Psychology has developed these really nice kind of booklet of career case studies for those who are qualified as health psychologists. So those with eagle eyes will notice that towards the bottom of that slide, there's a picture of me in the middle. And in this document, there are case studies, life stories of folks who've been qualified for a long time, like myself, and those who have just recently qualified as health psychologists or are almost completed. So it's a really nice way of seeing what you might be able to do as a health psychologist if you want to train as one, or if you want to employ one. So I've just put a list down the side of the slide of the very varied areas in which we might work, bringing a health psychology training and lens to these different areas. So there are things you might automatically think of with health psychology, like exercise, healthy eating, sleep, drug and alcohol use. But perhaps those where you might not immediately consider a health psychologist, like cardiac rehabilitation, for example. But thinking about how health psychologists work, we have something to bring to all these settings, and we certainly have good examples of trainees and qualified health psychologists who bring their behavioural science lens, who bring their work with health and illness to these different topic areas. So I'd encourage you to read further through the link on the slide, and we're happy to provide these after as well, if useful to you as a set of resources. Next slide, please. Thanks. So to train as a health psychologist, you need an undergraduate degree in psychology. We also have stage 1 training courses, which are masters in health psychology. And then a stage 2 training, so the sort of the professional training that leads you to qualification, starts at an Agenda for Change, that's the AFC bit, band 6. And a newly qualified health psychologist would come out of band 7. So very similar to other practitioner psychologists. And typically at the moment in England, folks are self-funding. So it's not like clinical psychology. Folks need to fund themselves, or they might be funded by an employer. So in some cases, in public health, for example, on a one-to-one case-by-case basis, students might be able to access funding by their employer. Now, in Scotland, they have a really nice model of funded training through the National Education for Scotland, the equivalent of HEE. And they fund 4 trainees per year, and that's been going for a long time, over 10 years, where trainees are recruited to work in different trusts in Scotland to undertake work that might be helpful, that utilises health psychology skills in each of the regions of Scotland. But until now, no such route has been developed in England that is funded in the same sort of way. So that's something we've all been keen to address throughout our careers. Next slide, please. So there are just kind of 3 different ways to move through your health psychology journey. And just for anyone who's listening who does want to kind of work in health psychology, I just thought I'd pop this slide up. The bit we're focusing on today is route 2, which is the stage 2 qualification in health psychology through the BPS, because that's kind of what our project is emulating and attached to. But there are other ways to train as a health psychologist. So the BPS accredited route at the top is normally through a university and also gives you the title of doctor. And the one at the bottom is a research qualification that makes you a health psychology researcher. But the bit in the middle is about working with the BPS to develop your qualification. Now, I'm conscious of time because we started a bit late, so I'm just going to move on from this slide now. But if anybody does want to find out more, you'll be able to find this slide and more information at the link at the bottom of the slide there around careers in health psychology. Next slide, please. Next slide, please. That one, thank you. So I'm just going to pass over to Lucy to tell you a little bit about making your health and care psychological in the NHS.
Lovely, thanks Liz. Great introduction to all things health psychology there. So I'm now just going to talk through the connection really between what Liz has talked about in terms of health psychology and what falls more within my remit in terms of workforce transformation and redesign. So I think you'll probably all agree, I think it's really evident that the skills and experience that health psychologists have can enhance the NHS workforce in quite a number of ways, including obviously the part we're talking about today in terms of helping to make all health and care psychological. And that really is why we are currently developing the programme that Liz mentioned that will focus on applying health psychology to workforce transformation and redesign specifically. So there are huge opportunities in this area for health psychologists to have a positive impact, and the transformation agenda will really benefit significantly as well by applying health psychology. So we are underway with some work in this space, which is what we'll be talking to you about shortly. So first of all, just to talk a little bit about what we mean when we mention workforce transformation and redesign. And so we use both of these terms to talk about a similar agenda, and that's really about redesigning the way that people work and the way that our services work. So transformation in a really broad sense is around a process of quite profound and radical change that takes an organisation in a new direction and to a different level of effectiveness. But when we think about this from a workforce perspective specifically then, this really involves understanding the future of work. So what's our current situation, what do we have now, but also what does the future look like? It involves exploring broader skills requirements, so looking beyond traditional competencies and roles. So we're thinking about moving across organisational and professional boundaries, for example. It involves nurturing a future integrated workforce, so a workforce that's more agile and flexible and able to respond to changes in the way that we work and in the way that services are delivered as will be required. And it's about supporting leaders and talent at all levels within the NHS to optimise delivery and to really grow for the future. So I suppose in summary then, there are some kind of key elements that we're referring to when we're considering the needs in terms of workforce transformation and redesign. So the connection between health psychology and workforce transformation and the opportunity to link these up is evident in the NHS People Plan, which is the plan that sets the strategic direction and requirements in terms of workforce within the NHS, and it's what we're working to deliver at the moment. So this plan sets out a commitment to supporting workforce redesign by supporting organisational development. And it specifically identifies the need to design both integrated services and integrated workforce focused on the broader social determinants of health. So redesign of our current workforce is crucial to this. So it's about supporting the achievement of what we want to do within the People Plan in terms of workforce, but it's also about supporting the other plans that set our strategic direction within health and care and the future of health and social care. So things like the long-term plan that set out what that needs to look like going forward. And so the programme that we've mentioned, the programme of work that we are currently developing, is around a health psychology approach, and that will be embedded within all of the regions across England and within our integrated care systems. And that will really enable socialisation of the psychology of change within those regions and within those systems, helping to grow capacity and capability in the workforce to take on this challenge and to make the changes needed to deliver the transformation required, as set out in those plans and as set out in the kind of ambitions that we've got within health and care. So we just want to now show you a short video that explains a little bit more about why we want to take a psychological approach to workforce redesign and how this approach can be applied into health professional behaviours specifically.
As healthcare professionals go about their work, they do or don't do things that will lead to positive or negative outcomes for patients. Healthcare professionals take part in training throughout their careers. Training changes the capability of healthcare professionals. The competence and capability that a healthcare professional has will obviously influence how well they do vital tasks. However, being competent or capable is not the whole story. Evidence suggests that just because someone can do something, it doesn't mean that they will do it. Other than capability, what else do you suppose determines whether a healthcare professional does or does not do a particular task? There are many psychological determinants of practice, and it's helpful to think of these under the umbrella terms opportunity and motivation. Opportunity is physical opportunity, having time and resources, like equipment and other people to help. But it's also social opportunity, believing that other people think that what you are doing is the right thing to do. In this context, motivation is not general energy or enthusiasm. Motivation in this context means motivation about the specific task that the healthcare professional is doing. It can be understood as automatic and reflective. Reflective motivation is a weighing up of pros and cons. For example, will the task lead to better outcomes? Is the task easy or hard? Automatic motivation is being prompted to do something. For example, by your previous behaviours or habits, or by cues in the environment. If attempts to change healthcare professional practice are to be successful, it is crucial to understand what determines behaviours. There is no point having training to increase capability if the healthcare professionals are already capable, but things like opportunity or motivation are getting in their way. The good news is that there are techniques to help people overcome opportunity and motivation barriers, which, if added to training, could make practice change more likely. The Change Exchange is a Manchester Implementation Science Collaboration project hosted by the University of Manchester. This work is funded by grants from the Tropical Health and Education Trust, with the Department for International Development and the Global Health Exchange.
Great, so the video that we just played there really shows the current understanding about what makes health professionals change practice and what potentially gets in the way. So one of the important things to consider here is the things that we try when we want to get people to do things differently, or we want to change behaviours ourselves possibly. So a kind of general example, I suppose, would be the example of shouting at children to get them to change their behaviour. Or if we're thinking in workforce terms, it would be focusing on training and education. But often we find that people know what they're supposed to be doing, know how to do it, but it's still quite difficult to shift that behaviour. So it's potentially more about culture, for example. So bringing a psychological approach to workforce redesign gets us thinking then about what is getting in the way of teams and individuals changing what they do, and what is and isn't successful in terms of the redesign that we're saying is needed. So it helps us to also think about what we can do and to address those things and to support these changes to happen. So I'm now just going to hand back over to Liz to share a little bit more information about behaviour change and our programme of work.
Hi, next slide, please. Thank you. So we've jumped over a couple there. That's okay. As Lucy was saying, there we go. Thank you. So as Lucy was saying, often we try ways to change people's behaviour, and I know I do it sometimes with my kids. I try to be psychologically informed, but we try ways that perhaps are not helpful. People know exactly how to put their shoes on for school, and just telling them to do it is not necessarily going to get the desired effect. So what else do we look to as health psychologists to help move people from an intention to engage in a behaviour to perhaps the behaviour itself? So next slide, please. So mentioned in the video was this idea of the COM-B framework, and this thinks about perhaps the thoughts, feelings and behaviours associated with kind of what people might be thinking and feeling when it comes to a particular behaviour. So if we apply the capability aspect to health behaviour in a healthcare setting, it might be that people know what to do, or perhaps they don't know what I'm meant to do or how I'm meant to do it. So considering that as a factor, do people have the capability or not? And what might our intervention need to be? Might it be more training, or might it be that actually that's already been sorted and that people do know what they need to do? But perhaps, as the video said, there might be areas in motivation. So I want to do it, but I seem to forget and I just do what I've always done. So people perhaps fall back on habits, or I know what to do and how to do it, but I don't actually think it's a good idea. I'm not very motivated, and we perhaps need to change hearts and minds on that particular aspect of health behaviour. And it might be opportunity, and I think we see this an awful lot, don't we, in terms of my working life as well. My boss tells me not to do it, my patients object to me doing it, or don't enjoy it, or it's unpleasant, or I don't actually have access to the stuff I need, or that really crucial one, I don't have the time to take on this behaviour change. And I think that is really, really key. We often hear that when we work with healthcare professionals. So health psychologists can help us think about these different factors and make the healthcare system and health professionals perhaps consider how to change behaviour to improve outcomes. Next slide, please. So what are we doing then? Bringing together the health psychology that we've introduced you to and the workforce redesign idea and the COM-B model? Well, we've got this new innovative project that Lucy and I are leading with the team that we introduced you to at the start. And it's embedding stage 2 trainee health psychologists in the 7 regions in England, so 1 in each, supporting region systems and organisations with workforce redesign. And they're hosted within a single employer, but they would work across the wider region. And they're going to apply the COM-B to redesign projects. So that might be clinical pathway improvement work or known cultural workforce challenges. And as well, as we said at the start, their training also encompasses a number of different skills that they'll be able to apply whilst they're in that role, but they will also have this focus to kind of bring together their work. They'll be supervised by health psychologists, myself as the National Training Director, and our steering group. And we have a really robust evaluation that we're planning that will be undertaken independently so we can evidence what works here potentially with this project and what we might improve if we want to roll it out in future. And trainees will also engage in some iterative evaluation too. Next slide, please. So I'm just going to pass over to Lucy again to explain why this is so important for workforce redesign.
Thanks, Liz. I'll just bring up those arrows. Fab. So why this offer? What are we looking to and hoping to achieve through this programme of work? So it will help to grow the workforce and to socialise behaviour change. So it will provide access to expertise in this area. It will support our existing workforce to understand this area, and will benefit them because they'll have the experts working alongside them to support the work that they're trying to do as well. It also means that the trainees that are on the programme are then working within workforce in our regions, in our systems, in our organisations, and they're able to directly apply their expertise to the key interventions, the key programmes of work around redesign where change is needed. So we get the direct application of the expertise and the skills there as well. As Liz mentioned, it will also create a national group via the trainees and their supervisors. So as a group, they'll be bringing their own experience and expertise, and they'll all be kind of collaborating, working together with our existing workforce as well on redesign and transformation initiatives to really make a difference where it's needed and to push this work forward. And we also mentioned the evaluation aspect as well. So the programme will entail quite robust evaluation, so we can understand where this had the most impact, where it worked, and can think about how that helps us to consider a future national plan to really maximise the impact of health psychology within workforce redesign. So as mentioned, we are in quite early stages of this work. Liz will be working with us for the next couple of years as National Training Director to develop and support the work. As Liz mentioned as well, we do have the team introduced at the start who are all contributing to moving this forward. We're looking to recruit the 7 trainees and their supervisors early into 2022, with the trainees being employed for 2 years to work in the way that we've described within our regions on workforce redesign. We'll start the programme of evaluation as we recruit the trainees, so we can really learn at every stage of the programme to inform how we introduce this going forward, and we inform future work in terms of redesign and how we can really maximise the impact in this way. This will help to support growth of careers of health psychologists themselves, so it has that benefit, but it will also help to successfully deliver our programmes of workforce change, workforce redesign, and the interventions that are needed. So it will help to move that agenda along. So it will have a direct impact for the trainees for health psychology, and also a direct impact for our regions, our systems, and our organisations within the NHS. The application then of the expertise and the work of the trainees alongside the other colleagues that they'll be working with and who are supporting this programme, the delivery of training to our broader workforce will really create additional capacity and capability in our existing workforce around behaviour change and around health psychology, so that we can look to then continue to apply this beyond the kind of work of the 7 trainees. So like I said, we can really maximise the positive impacts that this can have. And in summary, then, this is all aligned to and supportive of the ambition and the things that we're talking about today in terms of making all health and care psychological, and really maximising the impacts that we can have for workforce and for our services and for the patients that receive those services. And I will just hand back over to Liz for some closing words. Thank you.
So in summary, we hopefully have given you a sense of health psychology and who health psychologists are, where they work, what we can do in the workforce, introduced our pivotal role in making all health and care psychological, highlighting the role of workforce redesign and growing this capability and capacity for behaviour change and for health psychology in the workforce, and outlined our new training pathway pretty briefly. But if you want to know more, please do get in touch. We're really passionate about this project and would love to speak to you. We're going to have a little very quick question and answer session at the end, I think. But just on the next slide, please, I'd just like to thank really everyone in the project, as well as myself and Lucy. There are a number of folks who've really got this project off the ground, not least Adrian Whittington, National Lead for Psychological Professions, but also Jo, Lucy and Angel working from their respective universities, but also through the British Psychological Society and their various other important roles in health psychology to make this a reality. So it really is the culmination of lots of hard work in looking for opportunities really where health psychology can make a difference to make all health and care psychological. So whilst we had the pleasure of introducing this today, it's very much a team effort. So I think that's all we wanted to say in terms of our presentation. We were a little bit squeezed for time because we went a bit over with the first one, but we have got a little bit of space, I believe, for questions. So I think it's time to hand over back to Sharon.
Thanks, Liz. Sorry, my poor chairing. But we've got some time. We've got some time. Can I just introduce, I think, Angel's here. Hi, Angel. I introduce you all to Angel Chater, who's the Professor of Health Psychology and the past chair of the British Psychological Society Division for Health Psychology. So she's come on to support answering some questions this morning. One thing so thank you very much. I was looking forward to this presentation because I am also one of those people that are very keen to think about the employment of health psychologists in my own organisation. So this was great to hear about the health psychology route and training. One of the questions that have come through is, what is it, and it's inverted commas, unique contribution that health psychologists can make to the NHS, and how should this be integrated with other psychological professions? So it's not quite related to the second part of your, well, it may be. I'll leave you to interpret that.
Angel, do you want to take that? Because I'm conscious you haven't had a chance to speak yet, and we might not be able to hear your insights otherwise. So.
Okay, thanks for the question, and well done, Liz and Lucy. Brilliant presentation. I think we have unique contributions in terms of a lot of our training is around physical health and around the integration of using a biopsychosocial model, looking at physical health and the combination of that integrated with mental health, both from prevention and from treatment. I think what would be wonderful is to see all the psychological professions working together and health psychology working with our clinical psychology and counselling and other colleagues, and being able to bring what we bring in understanding behaviour and behavioural science to all the different areas in which psychology can support health and social care. So I think a lot of our expertise is around behaviour change, but it's not just about that. It's about understanding how health conditions might be influenced by that holistic environment that people live in, you know, their thoughts and feelings, but also their social factors, their environmental factors. And that COBI model is something that's situated quite strongly within the health psychology tradition, and really understanding those different drivers of behaviour and how that's linked to different outcomes. So, Liz, you might want to add to that from your background.
Yeah, I think about what we what we don't do. I mean, we don't tend to work so much with some of the things that we talked about in the first talk, like trauma or severe and enduring mental health issues as well. So I think there's something about we can complement in those situations, perhaps around exercise, healthy eating and sleep, some of the other health behaviours that we've talked about. But our training is around working with folks around their health, perhaps where they don't have mental health issues as well. So health promotion, working in connection with public health. So I think we span those two areas really. So there might be a mental health aspect to it, but there also might not. We might be working with folks who really want to lose some weight, want to stop smoking, want to need to adhere to a new medication. So I think there's lots of areas where perhaps it may not perhaps be needed that someone who has that really in-depth experience of working with people with mental health issues needs to be placed. Perhaps a health psychologist might be able to do that job that perhaps is something that takes up a lot of time in a service, but maybe doesn't need that level of expertise in severe and enduring mental health. So, for example, we have health psychologists in Scotland who might work in kind of secure units, but they might be working to help patients to go for their vaccinations or have their dental appointments. So the sorts of health behaviours that may be really important to the effective running of a service, but may not be something that easily fits under somebody's existing job role. So I think we can also kind of sort out some of those issues for services really where it's not really anybody's job a lot of the time, and it perhaps needs to be. So we've seen health psychologists in Scotland do a really, really effective job of providing a good solution to some of the problems that are happening in services.
Thank you both so much. I think in those two responses has answered that first question and many others that came up in the Slido. So thank you. That's really helpful. Unfortunately, that's the only question I'm going to have to ask this morning. But I think both you and our first presenters have done a wonderful illustration of the breadth, I think, of what the psychological professions can offer within health and health and social care. So thank you so much for coming this morning, and thanks Suzanne, Jenny, Sanya and Rachel. So I'm going to move us on then to close up the session for today. I think, as I said, we've focused a lot, and I think we've had some fantastic presentations this morning about the role of psychological professions in making all health and care psychological. Next slide, please. So if you have any comments, if you'd like to comment on these commitments, have any questions, would like to contribute to the discussion, please use our hashtag or at PP Intergalactic Bridge. Thank you. And tell us what works for you, give us your comment, engage with us, have a conversation. And then if you're in the North Eastern Yorkshire, please join the PPM. There'll be free evaluation questions that just been put in Slido, in the Slido window. So before you go, please give us your feedback. It'd be really important to hear what you think about today's session. And don't log off yet, because to download your certificate of attendance, you need to click the button underneath this window, the stream window. So please make sure you do that before you leave. I've had a great morning. I hope you've enjoyed spending the last, an hour and a half with us, and enjoy this afternoon session. Bye-bye.